usually when we talk about getting a medical diagnosis, there's this expectation of just absolute precision.
Right, yeah, like it's math or something.
Exactly. It's supposed to be like engineering. I mean, you break your arm, you go into a clinic, and the X-ray shows that, that jagged white line on the black background.
Yeah.
And the doctor just points at it and says, there it is. That's the problem.
It's definitely a comforting thought. I mean, we desperately want biology to be binary.
Yeah, broken or not broken.
Exactly. Infected or clean. We want things to be visible and easily categorized into these neat little boxes.
But then, you step out of that idealized textbook and into the actual sprawling world of systemic healthcare.
Yeah.
And suddenly that X-ray machine it's broken.
Where the machine works, but the building housing it is operating on a totally different set of rules.
Right. You're looking at this diagnostic and institutional landscape that just isn't clean. It isn't binary. It is profoundly murky. And I think that brings us to the core paradox we are unpacking today for you, the listener.
And it's a big one.
It really is. We're asking, why does the medical establishment, which is, a global system theoretically built from the ground up to save human lives, why does it historically destroy the very people who invent life-saving preventive tools?
It is arguably the most terrifying question you can ask about modern medicine.
Right, because on the surface you have the Hippocratic Oath. That's the guiding light, right?
First, do no harm. Prevent illness. But when you bypass the PR and look directly at the historical records and the psychological profiles of institutional leadership and, of course, the raw economic incentives,
you see a completely different reality.
You really do. And we are going to look at this specifically through the lens of patient-centered, prevention-first AI triage systems.
Right, specifically a framework known in the research as CALREM, or Dr. Maya GPT.
Yes, which is a system engineered to address some of the most existential threats we face today. Things like antimicrobial resistance, hospital-centric failures, and just the rampant normalization of fear-driven healthcare.
And what's wild to me is that the creators of tools like this, tools that can demonstrably, mathematically, keep people out of the hospital and stop pandemics in their tracks, they find themselves in this bizarre twilight zone.
Oh, absolutely. The private versus public reaction is staggering.
Yeah, they sit in private rooms with these professors, doctors, and policy experts who whisper, oh, this is brilliant. This is exactly what we need.
Right.
And then those exact same experts walk out the door and publicly refuse to engage with it or fund it or support its implementation.
The institutional wall just slammed shut. And to understand why that wall exists and, more importantly, how to build a bypass around it, we have to recognize that this is not a new phenomenon caused by AI.
No, it's an ancient immune response.
Exactly. It's systemic.
So I want to jump straight into that history because we, or at least I, tend to think of the scientific method as this pure, objective march toward truth.
We all like to think that.
Right. Like, if someone brings new data to the table that saves lives, the scientific community should throw a parade for them. But history shows us the exact opposite. We basically punish people for being right too early.
Punish for being right too early is, sadly, a tragically accurate summation of medical history. Let's look at Vienna in 1847. We really need to talk about Dr. Ignaz Semmelweis.
Yeah, the hand-washing pioneer.
Yeah.
But it's so much more than just a guy saying, use soap.
Oh, much more. We have to set the scene here. The Vienna General Hospital at this time was the absolute pinnacle of European medicine. It was this massive, highly prestigious institution.
Yeah, that's the best.
Exactly. And Semmelweis was working there looking at maternal mortality, specifically this horrifying condition called childbed fever, which we now know was caused by Streptococcus pyogenes.
Okay.
And he noticed a glaring statistical anomaly that would, frankly, haunt anyone who was actually paying attention.
What was the anomaly?
Well, the hospital had 2 maternity clinics. One was staffed entirely by faculty physicians and medical students. The other was staffed purely by midwives.
Okay. Doctors in one, midwives in the other.
Right. And the death rate for women delivering babies in the doctor's clinic was 10 to 20 times higher than in the midwife's clinic.
Wait, 10 to 20 times? That's not a rounding error.
No, it's a massacre. It's happening in one wing of the building and not the other.
That is just insane. The women must have noticed.
They did. Women literally begged on their knees in the streets not to be admitted to the doctor's clinic. They knew it was a death sentence. So Semmelweis, applying pure observation, starts to investigate.
Right.
And he realizes something absolutely horrific about the daily schedule of these esteemed doctors.
Uh-oh. What were they doing?
They were starting their mornings in the autopsy room.
Oh, no.
Yes. They were performing barehanded autopsies on women who had died the previous day of childbed fever. Barehanded, and then literally wiping their hands on their aprons, they would walk directly onto the maternity ward to perform vaginal examinations on pregnant women and deliver babies.
It's hard to even, hear that now. They were the vectors. The doctors themselves were literally carrying the disease from the dead to the living.
Precisely. They were transmitting what Semmelweis termed morbid poison. The midwives, on the other hand, didn't perform autopsies. That was the only variable. So Semmelweis proposed this beautifully simple, low-cost, preventive innovation.
Which was just washing their hands.
Right. He instituted a policy, wash your hands with a chlorinated lime solution before touching the patients.
It's the equivalent of, a biological fire extinguisher. You see a fire, you put it out at the source. And the math proved him right instantly, didn't it?
Instantly. The mortality rate in the doctor's clinic plummeted to match the midwife's clinic. The data was undeniable.
But how did the medical establishment react? Did they throw him that parade?
They destroyed him.
They absolutely dismantled his life, didn't they?
They did. The institutional ego completely fractured. You have to understand the psychology of the 19th century physician. They viewed themselves as gentlemen of science.
Right, the elite.
And the prevailing theory was that a gentleman's hands could not possibly transmit disease. The very implication that doctors were the vectors of death was an intolerable insult to their professional identity and their social hierarchy.
Wow. So they just rejected the data because it hurt their feelings.
Essentially, yes. His colleagues were outraged. The establishment mocked his data. They forced him out of his position at the hospital, and they blacklisted him.
That is so tragic.
It is. He suffered a severe mental breakdown from the rejection and, honestly, the guilt of knowing how many women were dying unnecessarily. He was eventually beaten by guards in an insane asylum and died of sepsis.
Sepsis.
Yeah. Ironically, the very type of infection he tried to prevent.
It's a staggering story. But here's where I want to push back a little, or at least play devil's advocate.
Yeah.
We look at 1847 and think, well, they didn't know about germ theory yet. They were just ignorant.
Right. That's the common excuse.
But it's not just a lack of knowledge, is it? It's an active refusal to accept the knowledge even when the proof is sitting right in front of them. It's like trying to introduce a modern fire extinguisher to a medieval guild of water bucket carriers.
Oh, that's a great way to put it.
Right. You walk in, you show them this red cylinder that puts out a fire in 3 seconds, and they don't see a life-saving tool. They see a direct threat to their bucket-carrying monopoly.
That is a phenomenal analogy. Their entire identity, their economy, their social standing, it's all built on the act of carrying the bucket, not necessarily putting out the fire. And we see this exact same dynamic repeat just a few years later in London with Dr. John Snow.
Right, 1854, the Broad Street pump.
Yes. So London is being ravaged by this massive cholera epidemic, and the established medical consensus of the time was the miasma theory.
Bad air, right.
Exactly. They believed disease was spread by bad air, by foul smells emanating from the Thames and the sewers.
Which is super convenient if you're in charge.
Highly convenient, because you can't really control the air. It absolved the city infrastructure of any responsibility. But John Snow, acting as a rogue outsider, decides to ignore the consensus. He starts mapping the clusters of infection, doing this grueling door-to-door boot leather epidemiology.
He's actually talking to the families, finding out where they get their water.
Exactly. And the data points him directly to a single contaminated water pump on Broad Street in Soho. He proves that cholera is waterborne. He isolates the root cause.
So he takes this airtight data to the local authorities, the Board of Guardians. And what do they say?
They resist him. They debate him endlessly. The medical establishment doesn't want to hear that their water infrastructure, the very system they oversee, is killing citizens.
Right, it threatens their authority.
And their established worldview. So what does Snow do? And this is the crucial moment for anyone studying innovation today. He doesn't wait for a peer-reviewed consensus. He doesn't ask for permission to change the policy.
What does he do?
He literally marches down to the Broad Street pump and physically removes the handle so nobody can draw water from it.
He just breaks the pump. He forces a proof of concept in the real world.
He completely bypasses the intellectual debate and alters the physical reality.
And it worked.
It worked. The cholera outbreak in that specific cluster collapses. He proved the value of a clean water supply and basically birthed modern epidemiology. But he had to act as a rogue agent to do it. The institution was paralyzed by its own established beliefs.
Wow. And we saw this again, didn't we, much more recently, in the 1980s with Barry Marshall and Robin Warren.
Oh, the ulcer story. Yes, this is a perfect modern parallel. Up until the 1980s, the medical establishment insisted that peptic ulcers were caused by stress, spicy food, and too much stomach acid.
Right. I remember people saying, don't eat that, you'll get an ulcer.
Exactly. And the entire gastroenterology industry was built around managing these symptoms with expensive, lifetime antacid prescriptions. It was a massive, highly profitable, bucket-carrying industry.
A huge moneymaker.
Huge. Then Barry Marshall comes along and says, no, ulcers are caused by a bacterium called Helicobacter pylori. We can cure it with a cheap 2-week course of antibiotics.
And the establishment, let me guess, laughed him out of the room.
They called him crazy. They said bacteria couldn't survive in the acidic environment of the stomach. They refused to fund his research. And the pharmaceutical companies, who were making billions managing the symptoms, certainly weren't going to help him prove that a cheap cure existed.
Of course not.
Mm-hmm.
So what did Marshall do? Did he break a pump handle?
In a way, yes. Much like Snow, he bypassed the system. He literally drank a beaker full of live H. pylori bacteria.
He drank the bacteria.
He did. He gave himself severe gastritis, and then he cured himself with antibiotics to prove his point.
That is wild.
He eventually won the Nobel Prize for it, but he had to resort to extreme measures because the medical hierarchy fundamentally rejects disruptive simplicity.
Okay, so if we pull these historical threads together, Semmelweis, Snow, Marshall, we see a very clear pattern. But how does this connect to the massive systemic crises we face today? Because the pushback against something like Dr. MyGPT isn't happening in the 1800s. It's happening right now.
The through line connects directly to the modern antimicrobial resistance crisis, or AMR. This is perhaps the greatest impending catastrophe in global health, and it was entirely engineered by institutional inertia.
Really? How so?
Let's go to 1954. Dr. Alexander Fleming, the man who literally discovered penicillin, is giving his Nobel Prize address, and in that speech, he issues a stark, explicit warning to the world. He says essentially, if you use this drug improperly, if you expose bacteria to non-lethal doses, they will mutate, they will become resistant, you will create superbugs.
Wow. So he gave us the warning label right out of the gate. Before the industry even fully took off, the inventor said, here is exactly how this will destroy us.
And the system completely ignored it. From the 1950s onward, we saw rampant, overzealous, historically unprecedented overuse of antibiotics.
Why? Why didn't they listen?
Because the healthcare system developed an intense desire to get people into clinics and hospitals. It became a transactional economy. Doctors started relying on rapid pharmaceutical interventions rather than clinical observation, patient education, or home-based prevention.
I see.
If an anxious parent brought in a child with a viral illness, which, remember, antibiotics cannot treat.
Right. Viruses don't respond to antibiotics.
Exactly. But the parent demanded a pill to feel better, and the doctor, acting within a system that monetizes the transaction and wants to clear the waiting room quickly, prescribed it reflexively.
We treated the greatest medical weapon in human history like candy. And because bacteria evolve rapidly, we basically trained the bacteria to defeat our best weapons.
We bred them in our own clinics. By prioritizing immediate transactional treatment over long-term prevention, the system actively engineered the AMR crisis. It is a perfect parallel to Vienna. Just as the doctors in 1847 couldn't admit their hands were dirty, modern institutions have spent decades struggling to admit that their overprescription and hospital-centric business models are breeding superbugs.
So the science is clear. Hand washing works. Clean water works. Antibiotics cure ulcers. Overprescribing causes superbugs. The institutions do not resist because the science is bad or the math is wrong. They resist because the innovation threatens their professional identity, their economic foundation, and the established hierarchy of knowledge.
That is the crucial takeaway from the history. When an innovation democratizes health, when it puts the power of prevention into the hands of a midwife in Vienna, or a citizen at a water pump, or a patient at home using an AI app, it inherently diminishes the centralized power of the hospital and the physician.
It takes away their leverage.
Exactly. The resistance isn't malicious in the comic book sense. It is an unconscious immune response by the institution to protect its own survival.
But wait, if the doctors themselves are suffering from this institutional ego, why doesn't the sheer weight of human suffering force a change? I mean, if we see millions of people dying or suffering, why doesn't the system naturally self-correct?
That's the logical question.
Right. That brings us to the psychology of the people running these systems. We need to look under the hood at the mental machinery that makes doctors, administrators, and policymakers behave this way. And the research provided for this deep dive introduces a fascinating and honestly slightly chilling concept here.
Yes, we have to talk about the concept of the Machiavellian doctor.
Okay, let's unpack this, because when I hear Machiavellian, I immediately picture a cartoon villain, steepling their fingers in a dark, smoky room, plotting to keep people sick.
Right, like an evil mastermind.
Exactly. But the analysis is very clear that this isn't about conscious villainy. It's about systemic, emergent behavior. We usually think of the Hippocratic Oath, first do no harm, but the premise here is that the operating system of modern healthcare is actually built on fear. How does that work in practice?
To understand the Machiavellian doctor, you have to look at how systems unconsciously use fear and information asymmetry to maintain control and compliance. Niccolo Machiavelli, in The Prince, wrote extensively about how rulers use fear, rather than love or logic, to maintain order among subjects.
Okay.
The psychological profiles of large medical institutions show they have adopted a very similar, albeit unconscious, dynamic.
Give me an example of how that starts. Where are the roots of this?
The historical precedent goes all the way back to the bubonic plague epidemics in medieval Europe. During the plague, doctors wearing those terrifying bird beak masks were the absolute only perceived line of defense against unimaginable suffering and a horrific death.
Right, people were desperate.
Desperate, and this created a profound, deeply ingrained dependency dynamic in the human psyche. The doctor held the secret knowledge of life and death, and the patient was reduced to an entirely powerless, terrified subject.
So the doctor is practically a god in that scenario.
Precisely. And that dynamic proved incredibly effective for ensuring total compliance. If you are terrified of dying tomorrow, you will not question the authority figure in the room. You will do exactly what they say, pay whatever they ask, and surrender your autonomy entirely.
It's the ultimate leverage.
It is. And in the modern iteration, institutions still rely heavily on the fear of illness, suffering, and death to elicit compliance.
Like how?
Think about how public health campaigns are often structured. They frequently use fear appeals, showing you the worst possible outcome of a disease, the blackened lungs or the grieving family, to make you take a vaccine, swallow a pill, or show up for a screening.
Oh, right.
Now, the intention might be to keep you safe, but the mechanism is fear. Furthermore, by monopolizing medical knowledge, by speaking in dense Latinate jargon, relying on complex lab tests that only they can interpret, and treating the human body like a proprietary machine that only a certified mechanic can understand, the system creates a paternalistic environment.
It treats the patient like a child.
Yes. It creates a paradigm where the patient is treated as fundamentally incapable of understanding their own body. You are taught from birth to outsource your inner knowing, your physical intuition, to the external authority figure in the white coat.
This makes so much sense, but here's where it gets really interesting to me. The analysis dives into some heavy psychological territory here, mentioning cognitive dissonance and comparing institutional behavior to the concept of the matrix.
Yes, the matrix analogy is very apt.
Let's explore that, because if a doctor's entire identity is built on being the savior who holds the secret knowledge, what happens when a piece of software comes along and gives that knowledge away for free?
This is a vital point for understanding institutional inertia. The system trains individuals, both the doctors inside the matrix and the patients outside it, to obey authority rather than trust their own observations. So what happens when a disruptive innovation like Dr. Maya GPT emerges? A tool that uses advanced pattern recognition to democratize diagnostic knowledge and put it directly on a smartphone in someone's living room.
It hands the power completely back to the patient. It makes the priest unnecessary to speak to the medical gods, basically.
And when it does that, it triggers massive systemic cognitive dissonance in medical leaders and administrators.
What exactly does that look like?
Well, cognitive dissonance is the severe mental discomfort you feel when your core foundational beliefs are directly contradicted by new, undeniable information. Imagine a hospital administrator who has spent 30 years of their life and millions of dollars of institutional capital believing that complex, expensive hospital infrastructure is the only valid way to deliver care.
Okay, I'm imagining it.
If you show them a low-cost, AI-driven prevention tool that works at home and accurately diagnoses an infection before the patient ever needs a hospital bed, that AI is a profound psychological threat.
It threatens their mental identity. It tells them their life's work is largely obsolete.
Exactly. So what does the human brain do to protect itself? It rejects the new truth. They suppress the innovation. They call it dangerous or untested. Not because it doesn't work, but because if it does work, it means their entire worldview, their social status, and their power structures crumble.
That is heavy.
The psychological analysis notes that a fully empowered individual who understands their own health is uncontrollable. Systems hate the uncontrollable. They want to reduce the patient to a manageable, predictable, fearful frequency.
Okay, let's look at the fallout of that. If you build a system based on paternalism and fear, and you strip away someone's free will and agency regarding their own body, what happens to the psychology of the patient?
They become hypervigilant and deeply neurotic. They lose the fundamental ability to distinguish between normal bodily sensations and catastrophic illness. And this is where we have to introduce two incredibly important, very expensive terms: viscerosomatic amplification and hypochondria.
Let's break those down because the financial cost attached to these psychological states in the research is staggering.
Let's start with viscerosomatic amplification. Let's break down the neurobiology here. Your brain is essentially a prediction engine.
Right.
It constantly compares visceral sensory input, say a slight twinge in your chest muscle or a flutter of gas in your stomach, with your expectations and fears. If the healthcare system has spent your entire life training you to be terrified of your body and to assume every unverified symptom is a potentially deadly disease that requires a doctor to decode, your brain's alarm system becomes hypersensitive.
It overreacts.
It will literally amplify that benign muscle twinge into a blaring, agonizing alarm.
So it's a self-validating vicious cycle. You feel a small pain. You get anxious because you don't have the health literacy to know what it is. The anxiety creates physical tension and autonomic arousal. Your heart rate spikes, you start sweating, your breathing gets shallow.
Yes, the fight or flight response.
Right, which actually makes the chest pain feel significantly worse, which then proves to your panicked brain that you are, in fact, dying.
Exactly. It's a top-down and bottom-up neurobiological loop. Your fear creates the physical symptoms that justify the fear. Now, combine that internal amplification loop with the modern internet, and you get hypochondria.
Oh, right. Dr. Google.
Yes. Patients who have been stripped of basic health literacy go online. They type chest twinge and sweating into a search engine. The search algorithm, which is optimized for engagement and click-through rates, knows that terrifying results get more clicks.
So it doesn't tell them it's indigestion.
No, it tells them they are having an acute myocardial infarction, a massive heart attack.
It feeds them the absolute worst-case scenario. And what is the real-world economic impact of that? Because it can't be cheap.
It is devastating to public health resources. Look at the data from the UK's National Health Service. The NHS spends an estimated £420 million every single year just on outpatient appointments related solely to internet-induced health anxiety.
Wait, what?
1 in 5 NHS appointments is driven by irrational, amplified fears rather than organic disease.
420 million. Let that sink in for a second. That's $500 million spent just treating anxiety disguised as physical illness.
And it gets worse when you look at emergency departments. Upwards of 12% of all patients presenting to the ER meet the clinical criteria for panic disorder.
12% of the whole ER.
Yes. And when the presenting complaint is chest pain, that number skyrockets to between 20% and 35%.
You're kidding.
Think about the magnitude of that. Up to a third of people rushing to the emergency room, tying up triage nurses, taking up beds, convinced they're having a fatal heart attack, are actually experiencing a panic attack.
A panic attack amplified by a system that has fundamentally taught them to fear their own biology.
Exactly.
And what does the hospital do with those patients? They don't just say, you're having a panic attack, go home.
No, of course not. Because of liability and protocol, the system runs expensive tests. They run EKGs, they draw blood for troponin levels, they order chest x-rays, sometimes even angiograms.
And all of that costs money.
A lot of money. And even when the tests come back completely clear, the patients often reject the reassurance. They think, oh, the doctor missed something, because the system hasn't given them the internal tools to understand their own anxiety. So the system generates the anxiety through information asymmetry, and then it turns around and highly monetizes the treatment of that very same anxiety through endless diagnostic tests and specialist referrals.
Wow. The system generates the anxiety, then monetizes the treatment of it. But wait. If the doctors themselves are suffering from this cognitive dissonance, why doesn't the free market fix it? Why don't hospital CEOs step in and say, we need to adopt this cheap AI to clear out our waiting room so we can focus on real emergencies?
Because that would ruin their business model.
Right. That brings us to the actual math of a hospital bed. Because fear and dependency aren't just psychological quirks of a broken system. They are the financial bedrock of the industry.
They are the foundation of the modern medical business model. And this is where we have to draw a razor-sharp contrast between the two competing philosophies of health. What we have now, which is GDP-driven healthcare, versus what we actually need, which is prevention-driven healthcare.
Let's really pull this apart for the listener, because GDP-driven healthcare sounds like an oxymoron. GDP is about gross domestic product. It's about maximizing transactions, moving money around.
More tests, more beds occupied, more pills prescribed.
More billable hours. But prevention-driven healthcare is about minimizing illness, keeping people out of the hospital entirely.
And those two goals are mathematically and fundamentally opposed. You cannot maximize transactions and minimize illness at the same time.
That makes sense.
Let's look at the financial architecture of a modern hospital. The analysis of the Indian hospital industry provided in the sources gives us a perfect, transparent look at the mechanics of this GDP-driven model. The financial data is incredibly stark. To build a standard modern hospital in India, it costs roughly 2 crores per bed.
2 crores. That's 20 million rupees for a single bed.
Yes. So imagine a healthcare corporation decides to build a mid-sized 500-bed hospital. At the exact moment they cut the ribbon at the inauguration ceremony, before a single patient has walked through the glass doors, they are in the hole for 1,000 crores. That is a massive, crushing, debt-funded capital expenditure.
Hold on. I've always thought of hospitals as these sort of benevolent public utilities, like a fire station or a library. But you're describing a highly leveraged commercial real estate venture with a medical facade. You have a billion-rupee debt hanging over the building like a guillotine.
That is exactly what a debt-funded hospital is. And that debt requires immediate, aggressive, relentless servicing. The banks want their money every month.
So how do they get it?
How does a hospital generate the massive cash flow needed to pay that debt? They employ highly aggressive commission-based models. They look for doctors in the community who already have a large, loyal patient base, and they lure them into the new hospital with commissions.
Like a percentage.
Say, a 20% cut of whatever gross revenue they generate for the hospital. They also use a predatory contracting system called an MG, or minimum guarantee.
How does a minimum guarantee work in medicine? I've heard of that in retail, but medicine.
The hospital guarantees a star doctor a massive fixed annual salary, maybe 3 to 4 crore rupees a year. It sounds great for the doctor, but there is a catch in the contract.
There's always a catch.
The doctor is contractually obligated to generate a multiple of that salary in hospital billing. If they are paid 3 crores, they might have to generate 15 crores in billable services.
So the doctors essentially put on a sales quota, like a car salesman trying to hit their numbers at the end of the month, but with human bodies.
Yes. The doctor is transformed from a healer into a sales agent for the hospital's infrastructure. And what happens to clinical judgment when you have a multi-crore quota hanging over your head? The system heavily incentivizes the doctor to overprescribe, overtest, and overbill.
Give me an example of what that looks like on a bill.
If a patient comes in for a standard knee replacement, the base surgical cost might be 2.5 lakhs. But the final bill handed to the family will be 4 lakhs because of added, often completely unnecessary, line items. Extra blood tests, extended hospital stays, premium branded medications instead of generics.
There's an absurd detail in the analysis that blew my mind when I read it. They mentioned that some hospitals literally charge different amounts for an x-ray depending on what body part it is, even if it uses the exact same machine and takes the exact same amount of time.
Yes, that is a real practice. They will charge more for an x-ray of your leg versus an x-ray of your chest using the same machine in the same room.
Why?
Because the pricing isn't based on the actual cost of delivery or the medical value. It's based entirely on what the market will bear, what the insurance will cover, and what the massive debt requires. The entire clinical ecosystem optimizes for maximizing the occupancy of those 500 beds and inflating the billing rates as high as possible. The patient's actual health is entirely secondary to the hospital's financial health.
It is a complete and utter abandonment of the ancient philosophy of medicine. The texts contrast this modern corporate monstrosity with Charaka, the ancient Indian physician and foundational figure of Ayurveda.
Yes, Charaka codified the ethics of medicine for humanity centuries ago. His foundational non-negotiable principle was that the physician must serve without greed or exploitation. The medical system must act as a shield for the poor, the illiterate, and the voiceless.
Which is beautiful.
It is. But the modern 1,000 crore hospital model operates on the exact opposite polarity. It actively exploits the asymmetry of knowledge, the fear and ignorance we discussed earlier, to extract maximum wealth from the most vulnerable people in their most desperate moments.
And this profit-first paradigm isn't just failing in the billing department, it's failing at the microscopic level. It is the exact reason why we are losing the war against antimicrobial resistance, right? The economics of pharmaceuticals are just as broken as the economics of hospital beds.
That is a terrifying reality, but it is entirely economically logical within this broken system. Why are superbugs winning? Because the economic model for developing new antibiotics is fundamentally incompatible with capitalism.
How so?
Let's look at the pipeline. To develop a single novel antibiotic from initial discovery in a lab, through clinical trials to regulatory approval and market launch, costs a pharmaceutical company roughly £1 billion.
£1 billion
Oops.
for one drug.
Yes. Now, put yourself in the shoes of a pharma CEO looking at the product life cycle of an antibiotic. If your scientists develop a truly phenomenal, highly effective antibiotic, a patient takes it for a week or two. The infection is completely cured, the bacteria are eradicated, and the patient stops taking the drug.
Right, they're cured.
They never need it again. Furthermore, because bacteria mutate quickly, public health officials immediately step in and demand that this new, powerful antibiotic be held in reserve. It becomes a last line of defense. Doctors are instructed not to prescribe it unless absolutely necessary.
So wait, let me get this straight. You spend £1 billion to make a product that works perfectly. It cures your customers so fast that they stop buying it in 14 days. And then the government locks your product in a glass emergency case, so almost no one is even allowed to buy it in the first place.
Exactly. It is a catastrophic, suicidal business model. Compare that to a drug that merely manages the symptoms of a chronic lifestyle disease, like a statin for high cholesterol or a daily pill for hypertension.
You take those forever.
The patient takes that drug every single day for decades until they die. That is a highly profitable, recurring revenue stream. Curing an acute infection quickly is wildly unprofitable.
Just bad business.
Look at the real-world example of an American biotech startup called Achaogen. They actually did it. They successfully developed a new, critically needed antibiotic for multi-drug resistant infections. They brought it to market.
And what happened?
And then they promptly went bankrupt because the sales volume was so low it couldn't sustain the company's operating costs.
That is incredibly bleak. So if we step back and look at the whole board, we've literally built a global healthcare system where a cured patient or a completely prevented disease is viewed economically as a lost customer. A completely healthy, resilient population would instantly bankrupt the entire modern medical infrastructure.
That is the grim, unavoidable reality, and it perfectly explains the institutional resistance we started this deep dive with. This is exactly why low-cost, highly effective prevention AI tools are privately discussed and praised by academics behind closed doors, but publicly avoided and suppressed.
Because it kills the golden goose.
Exactly. Supporting a software tool that keeps people healthy and at home actively threatens the 1,000 crore debt repayments of the institutional giants.
It's the fire extinguisher and the water bucket carriers all over again. If your entire global economy is built on selling highly inflated buckets of water to fight raging fires, you will use every ounce of your power to ban the fire extinguisher.
Precisely. The system is functioning exactly as it is economically incentivized to function.
Okay, so this brings us to the crux of the issue. How do you fix a system that is economically incentivized to stay broken? The answer is, you don't. You don't ask the bucket carriers for permission to put out the fire. You introduce an innovation that bypasses them entirely. And that brings us to the core case study of this deep dive, Dr. Maya GPT.
Enter the fire extinguisher. Dr. Maya GPT, pioneered by Dr. Karyali Srivatsa, is essentially the modern technological realization of Charaka's ancient vision. It is the digitization of ethical, highly accessible self-care designed specifically to bypass the institutional bottlenecks and protect the global population.
Let's get into the actual mechanics of this AI because we need to understand how it works. And it's not just another WebMD symptom checker that asks if your arm hurts and then tells you you have a rare brain parasite.
Far from it. To understand why Dr. Maya GPT is so disruptive, you have to look at its clinical origins. Dr. Srivatsa didn't build this in a Silicon Valley incubator. He built the foundation for this in 1996 in a hospital.
Oh, really?
Yes. It was originally called the Pediatric Assessment Tool, or PA. While working as a pediatric intensive care specialist in the UK's National Health Service, he realized that junior doctors and triage nurses were struggling.
What were they struggling with?
They were looking at critically ill children and relying on vague intuition or panic, leading to misdiagnoses. They needed a highly structured, mathematically reliable method to rapidly assess a patient. Instead of relying on gut feeling, he created a systematic, objective framework.
And that systematic framework evolved over decades into what the analysis calls the triad methodology used in Dr. Maya GPT today. I want to spend some time here. How does that differ from a normal algorithm? Because most apps just use decision trees, right?
Right. Traditional symptom checkers use rigid algorithmic binary decision trees. You input a symptom, say headache. The app asks a yes-no question. Is your vision blurry? If yes, go down path A. If no, go down path B.
That seems pretty basic.
It is. That is incredibly brittle, and it is not how a real, experienced human doctor thinks. A seasoned physician uses complex pattern recognition. They don't look at isolated symptoms. They look for specific combinations or constellations of signs.
It makes me think of music. A standard app looks at one note, maybe a C, and tries to guess the song. It could be anything. But Dr. Maya waits until it hears three notes played together, a C, an E, and a G. That's a chord. And once you hear the chord, you instantly know the exact tune.
That is a perfect analogy. Dr. Maya GPT uses this triad methodology. It requires three symptom combinations to recognize a clinical pattern: fever plus neck stiffness plus confusion.
Oh, that sounds bad.
That is the meningitis chord. That triad instantly identifies the specific clinical threat. This mirrors actual high-level clinical reasoning and drastically improves diagnostic accuracy over traditional linear apps.
But the real genius of it, the part that makes it a true systems-level bypass tool capable of scaling globally, is the interface. It doesn't spit out complex medical jargon. It doesn't tell a terrified mother that her child has acute bilateral otitis media. It uses a universal, color-coded system.
This is the critical innovation for global scaling and bypassing the information asymmetry of the medical matrix. The AI processes the complex triad, but outputs a devastatingly simple instruction categorized into 4 colors: red, yellow, green, and blue.
Walk us through the colors.
Red means emergency. You need an immediate doctor consultation. Go to the hospital now. Yellow means caution. A pharmacist or local clinic consultation is appropriate. Green means the condition is entirely suitable for simple self-care at home, rest, and hydration.
And blue.
Blue is the pandemic killer. Blue indicates a potential infectious disease requiring immediate isolation. It means you are contagious, stay in your room, do not go to the waiting room.
It's brilliant in its simplicity. It's exactly like giving every single person on Earth a dashboard warning light for their own biology. You don't need to be a mechanic to know how an internal combustion engine works. You just need to know that a flashing red engine light means you have to pull over immediately, and a green light means you're perfectly fine to keep driving.
Exactly.
By using colors, you instantly bypass literacy barriers, language barriers, and all the Latinate medical jargon the institutions use to maintain control.
Exactly right. It violently democratizes medical triage. It empowers the patient to know, with clinical sophistication and objective data, whether they actually need to walk into that 1,000 crore hospital and become a customer, or if they just need to stay in bed and drink water.
And predictably, because it empowers the patient and directly reduces unnecessary hospital visits, which threatens to starve the beast, the institutions tried to crush it.
The suppression was immediate, systemic, and multifaceted. Despite the tool's obvious, mathematically provable ability to prevent pandemics through early detection and the Blue Home Isolation Code, it faced massive resistance from the gatekeepers.
What did they do?
Well, when Dr. Srivatsa attempted to publish the Maya app to help people identify potential infections during global crises, Google Play flatly refused its publication.
Big tech acting as the enforcer for the medical establishment.
Yes. They cited policies about only allowing official government health apps. Furthermore, international health organizations, including the WHO and the CDC, were presented with this system and the data supporting it, and they simply ignored it.
Just ignored it.
Ignored it. Hospital administrators actively resisted implementing it in their triage flows. Why? Because the Maya system threatened the existing power structures. It threatened a system that benefits from complex, opaque processes that require expensive, centralized infrastructure.
Right.
If patients can safely and accurately triage themselves at home using a free or low-cost AI on their phone, the massive, fear-driven foot traffic that services the billion-rupee debt of the healthcare matrix dries up overnight.
So we have a life-saving tool, a literal fire extinguisher for global health. And we have the front doors of the medical institutions firmly bolted shut to protect their business model. The WHO won't help you, Google won't host you, and the hospital won't adopt you. If you are an innovator listening to this, and you are trying to implement a systemic change like Dr. Maya, what do you do? Do you just give up?
You absolutely do not give up. You stop knocking on the bolted door. You build a bypass.
This is where we get into the tactical application of everything we've discussed. If we know, historically and psychologically, that the institutions will block preventive AI, how do we actually scale it? The analysis outlines a very specific, aggressive 12-month tactical roadmap, and it's based precisely on the historical successes of rogue agents like Jon Snow.
Yes.
Walk us through this bypass model. What does day one look like?
The fundamental strategy here, the mindset shift you must make, is to stop treating the rollout as a medical software integration. If you try to sell this to a hospital purchasing committee or a university medical board, you will fail.
They'll just bury it.
They will stall you in committees until you run out of funding. Instead, you have to treat this as a grassroots systems-level intelligence operation. You are deploying a resilience tool directly to the population, circumventing the authorities entirely.
Okay, let's break it down. Phase 1, the first 3 months. What is the tactical move?
The first 3 months are about establishing unquestionable proof of concept outside the institutional gates. Remember Jon Snow? He didn't ask the London City Council to pass a law officially recognizing the waterborne theory of cholera.
You just remove the pump handle.
Right, and save the neighborhood. You don't ask for policy change, you create parallel legitimacy. You bypass the clinics entirely and deploy the color-coded system directly into the community. You partner with NGOs, women-led community networks, microfinance groups, and set up community health kiosks.
You go to the margins.
Yes. You target populations that are already underserved or actively exploited by the formal hospital system. In those communities, the AI provides immediate, undeniable value. It tells a mother instantly if her child needs to take the long bus ride to the city hospital, which is red, or if she can manage it at home, green.
So you prove it works.
You prove it works in the messy real world, not in a sanitized clinical trial controlled by the people who desperately want you to fail.
You build a fortress of grassroots data. Okay, so now you have a network of users.
Right.
What happens in phase 2, months 4 through 6?
Months 4 through 6 involve a concept we conceptualize as starving the matrix.
I love that phrasing. We touched on the quantum psychology analysis earlier. The idea that you defeat a massive control matrix, not by fighting it head-on, which just feeds it energy, but by withdrawing your attention and your compliance from it.
Yes. The hospital system, as we established, requires a constant, massive flow of anxious patients with minor ailments to generate the transaction volume necessary for revenue. In this phase, you train community health workers, people who may not be formal doctors but are highly trusted in their neighborhoods, to use Dr. Maya GPT to handle all the green and yellow cases.
The self-care and pharmacist-level cases. The people who are panicking over a benign chest twinge.
Right. By empowering the community to handle the green and yellow cases confidently with AI backing, you vastly reduce the foot traffic to the formal hospitals. You siphon off the unnecessary emergency room visits.
You take away their customers.
You withdraw the energy, the terrified patients that the fear-based system relies on to survive. You don't fight the hospital. You just make it irrelevant for 70% of daily health concerns. The hospital suddenly finds its waiting rooms emptying out.
You hit them in the only place they feel pain. The billing department. Okay, phase 3, months 7 through 9. How do you accelerate this?
Phase 3 is about leveraging crisis. There's research from Yale Insights that explicitly notes that frontline innovations usually face years of impossible red tape. But crises create sudden, massive windows of opportunity if the advocates are positioned to move fast.
Don't let a good crisis go to waste.
Exactly. You don't sit around waiting for a once-in-a-century global pandemic. You use local, seasonal outbreaks.
Like a seasonal influenza surge or a regional dengue fever outbreak during monsoon season.
Exactly. Every year, there are predictable surges that overwhelm local clinics. When the traditional system is visibly buckling under pressure, when there are people sleeping in the hallways of the hospital and the administrators are panicking, you aggressively pilot the blue isolation protocol of Dr. Maya in your established grassroots network.
Show them what it can do.
You show the community that the AI can instantly identify the infectious cluster. It guides them to self-isolate at home, breaking the chain of transmission, protecting their families without needing to sit in a crowded, highly infectious hospital waiting room.
You become the lifeboat while the Titanic is taking on water. You prove the system's value when the legacy system is failing publicly. And then finally, phase 4. Months 10 through 12. You've built the lifeboat. How do you solidify this bypass so the government is forced to adopt it?
You completely flip the script on the economics. Phase 4 focuses on the anti-corruption and efficiency angle. You stop talking to doctors about medicine altogether.
They won't listen anyway.
Exactly. You start talking to finance ministers, treasury officials, and government auditors about economic efficiency. The analysis provides a brilliant real-world precedent for this from India.
Oh, the PMJAY smart cards tell that story.
The Indian government rolled out the PMJAY smart card system, essentially a massive public health insurance scheme to subsidize health care for low-income populations. Their goal was just to pay for care. But inadvertently, because the billing platform was digitized and centralized, it became a massive AI-powered fraud detection tool.
Wow, an accidental auditor?
Yes. By digitizing the transactions, the government suddenly had a macro-level oversight over millions of hospital interactions. The system's algorithms automatically detected over 18,000 fraudulent insurance transactions. It caught hospitals claiming to perform surgeries on patients who weren't even there. The government penalized and de-empaneled corrupt hospitals.
It caught the institutions padding the bills to hit their minimum guarantee quotas.
Precisely. So, your final move is to position Dr. Maya GPT to governments not as a medical device, which triggers the medical lobby to attack you, but as a macroeconomic audit and triage tool.
That's incredibly smart.
You show the finance minister that by triaging patients effectively at home, the AI prevents hospitals from admitting patients unnecessarily just to hit their quotas. You show the government that Dr. Maya reduces wasteful public health spending and catches systemic fraud before it happens.
You align the AI with the government's inherent desire to save money, pitting the state treasury against the greedy hospital system. That is pure Machiavellian tactics used for ultimate good. But to execute this 12-month roadmap, to get those NGOs to trust you, to get those community workers to use it, and eventually to get those government auditors to back you, your messaging has to be absolutely bulletproof.
It has to be airtight.
Right. You can't just walk in with a good idea. You need data that is so devastatingly clear that no academic committee can dismiss it without looking completely corrupt or totally incompetent.
Which brings us to our final and most crucial section, the evidence-based playbook. If you are an innovator, an advocate, or a policymaker listening to this deep dive, these are the 5 undeniable talking points you must use in your pitch.
Let's lay them out. I want to imagine I'm pitching this to a skeptical finance minister. Point number 1, the economic lockdown metric.
You have to fundamentally reframe the tool from a health app to a national security and pandemic resilience shield.
Wow.
The economic data regarding how we handle infections is staggering. During the COVID-19 pandemic, the legacy approach was full lockdown policies, shutting down the entire global economy, destroying small businesses, halting education.
It was brutal.
The estimated cost of that blunt force strategy was $697,121 per life year saved. It was macroeconomically devastating.
Almost 700,000 euros per life year. That is unsustainable for any nation.
Exactly. Now, compare that to the Dr. Maya Blue Code strategy. Early community detection through AI, followed by targeted individual home isolation. You don't lock down the city, you isolate the specific node of infection. That strategy costs only $206,888 per life year saved.
That's less than a third of the cost.
It literally saves economies from collapse. You present this hard math to a policymaker and ask a simple question. Minister, next time a virus hits, do you want to bankrupt your nation with blind medieval lockdowns, or do you want to use an AI shield to isolate only the infected for a fraction of the cost while keeping the economy open?
They can't argue with the math.
Okay.
Point number 2,
Sure.
the viral cluster proof.
This is your clinical ammunition to prove the Blue Code works in reality, not just in theory. In a documented real-world cluster of 120 users during a severe flu season, patients who used the Maya system for early triage and self-isolation prevented an estimated 35 secondary cases in their community.
And the control group?
The control group, which relied on the traditional system of waiting until they felt terrible and then going to a crowded clinic, that resulted in 18 secondary cases.
Wait, I want to make sure the listener grasps the magnitude of that math. The AI prevented an estimated 35 secondary cases compared to 18 in the control group.
Yes. By cutting the chain of transmission early, at home, before the patient ever walks into a clinic and coughs on a waiting room full of vulnerable people, the AI demonstrates mathematically undeniable superiority in infection control. It is a firewall for the community.
That is massive. Okay, moving to point number 3, the cost reduction reality.
This point speaks to the everyday, grinding financial burden on families and the state healthcare budget. Dr. Maya reduces unnecessary healthcare visits by 55% compared to traditional, rigid, algorithmic symptom checkers.
55% of clinic visits just eliminated entirely.
Yes, because it gives patients the objective confidence to stay home when they have a green code. But more importantly, it stops the devastating polypharmacy burden.
Explain polypharmacy.
When a healthy patient goes to a hospital unnecessarily because they are anxious, the doctor, trying to hit their MG quota, subjects them to a cascade of unnecessary prescriptions, polypharmacy. The analysis shows that polypharmacy currently inflates global healthcare costs by a staggering 198%.
198%.
Yes. By keeping healthy, anxious people out of the hospital ecosystem entirely, Dr. Maya instantly slashes that 198% artificial inflation.
You aren't just saving the government the cost of the initial doctor visit. You are saving them the cost of the 5 unnecessary, expensive pills the doctor would have prescribed and the cost of treating the side effects of those pills. It's a compounding economic victory. Now, point number 4, the meningitis speed to care metric. I love this one because it directly attacks the medical lobby's main argument.
Yes, the establishment will always argue that AI is dangerous and will miss critical diagnoses. This point destroys that argument. Let's look at a critical, time-sensitive case. Meningitis. A traditional liability-terrified symptom checker app often tells a patient with a headache to seek care within 24 hours, or at best, 6 hours after the onset of severe symptoms.
6 hours with bacterial meningitis can be fatal. The brain swells. That is a massive liability.
It is deeply dangerous. But Dr. Maya's triad methodology is actively looking for the specific pattern. Fever plus neck stiffness plus confusion. If it sees that triad, it doesn't wait. It instantly triggers a red-blue code and recommends emergency evaluation within 1 hour.
That's fast.
In documented cases, patients using this system reached the hospital 5 hours earlier, and life-saving intravenous antibiotics were administered 4 hours sooner than if they had relied on traditional app advice or waited to see their general practitioner the next day.
That is the golden hour of medicine. That is undeniable clinical superiority.
Yeah.
You look the medical board in the eye and say the AI isn't just cheaper. It's definitively faster and safer in critical life or death scenarios. It is saving lives while your traditional algorithms are still asking the patient if their throat is scratchy.
It completely neutralizes the safety argument used by gatekeepers.
And finally, point number 5, the restoration of patient free will.
This brings us full circle to the psychological profile we built at the beginning of the hour. Traditional systems actively amplify symptoms through uncertainty. They thrive on the information asymmetry that keeps the patient guessing, terrified, and dependent.
Right.
That dependency leads to excessive reassurance-seeking behaviors, decision paralysis, and the 420 million wasted on NHS cyberchondria appointments.
This system makes you crazy and then charges you an exorbitant fee for therapy.
Dr. Maya cuts through that psychological manipulation like a scalpel. By giving the patient a clear, color-coded, triad-based understanding of their own biological data, it restores autonomy. It restores health literacy. It empowers the individual to break the vicious neurobiological cycle of fear and dependency. You tell policymakers that implementing this AI isn't just about software. It is how you cure the epidemic of cyberchondria that is currently clogging their emergency rooms and draining their budgets.
So if you are listening to this and you are trying to scale a disruptive innovation, the playbook is incredibly clear. You do not argue with the doctors about medicine or turf. You will lose that battle. You argue with the policymakers about national security, pandemic economics, hospital wait times, and fraud reduction. You completely change the battlefield.
You step out of the hospital entirely and you empower the community. You give the fire extinguisher directly to the people whose houses are burning.
This has been an incredibly eye-opening, expansive journey today. Let's summarize what we've unpacked. We started by looking at that simple X-ray, the human desire for clarity, and we realized that the systemic resistance to clarity is a feature of the medical establishment, not a bug. From Semmelweis being run out of Vienna and driven mad for suggesting doctors wash their hands, to John Snow having to act as a rogue agent to break the pump handle in London, to Barry Marshall drinking bacteria, to the modern bureaucratic suppression of Dr. Maya GPT, the pattern is absolutely, terrifyingly identical.
It really is.
Institutional resistance isn't a sign that an innovation is wrong or dangerous. Historically, fierce institutional resistance is the ultimate, undeniable proof that an innovation is truly disruptive and fundamentally necessary.
The institutions, bound by their egos and their massive financial bets, will always protect the buckets. It is entirely up to the innovators, the rogue agents, to distribute the fire extinguishers anyway.
As we wrap up this deep dive, we want to leave you with a final provocative thought to mull over, something to explore on your own that builds on everything we've discussed today. If AI systems like Dr. Maya successfully execute this bypass strategy, if they use this 12-month roadmap to put diagnostic power and true health literacy directly into the hands of the community, permanently starving the matrix of its fear-driven revenue, we might not just be looking at the end of corporate hospital monopolies. We might be witnessing the evolution of a fundamentally new kind of human society, one where your first line of medical defense isn't a massive debt-ridden infectious building you drive to in a blind panic. Instead, it is a deeply personalized, highly intelligent system that lives quietly in your home, understands your unique biological baseline, empowers you to heal yourself, and catches the next global pandemic before it ever crosses your front door.
It shifts the entire paradigm of human existence from anxious reaction to sovereign resilience.
So ask yourself this as you go about your week. What happens to the empire of fear when the patient simply stops being afraid? Thank you so much for joining us on this deep dive. Stay curious, keep questioning the systems around you, and always remember that true health begins with your own empowerment.